Yes, you'll get 1 minute to read.
Yes, ma'am.
Right, so if you've read and understood, considering it surgical pathology station, please tell me what is your provisional and differential diagnosis of this patient?
Madam, my provisional diagnosis is metastatic malignant melanoma, and the
Okay,
differentials are squamous cell carcinoma and lymphoma and basal cell carcinoma.
all right. How would you confirm your diagnosis?
To confirm the diagnosis, I would take a biopsy of that particular sample and do histopathological studies like frozen section. If we are doing intraoperatively, then we can do frozen section. If we are doing in outdoor cases, that we need to do histopathological studies and immunohistochemistry to rule out the exact diagnosis of this
What
patient.
are the different types of malignant melanoma?
There are 5 different types of malignant melanoma. The most common one is first one is superficial spreading melanoma. Second is lentigo-maligna melanoma. Third is desmoplastic melanoma. Fourth is acral melanoma. Fifth is nodular melanoma.
Please define the term epithelioid melanoma.
In melanoma, there are basically 2 types of cells: epithelioid cells and spindle cells. The epithelioid melanoma is basically consists of epithelioid cells. Epithelioid cells are large ovulated cells uh, which have which has abundant
Abundance.
eosinophilic cytoplasm,
Yes, yes.
abundance of eosinophilic cytoplasm, and a large nuclei. And this type of melanoma is basically present in the superficial spreading melanoma and nodular melanoma.
In order to confirm your diagnosis, you would have to examine the patient. Where exactly
Yes,
are you
ma'am.
going to start your examination? Or where
So the
would be the
examination is
concluding examination? Yes.
Yes, ma'am. The examination is local examination and the metastatic examination. In local examination, I would like to do examination of the both lower limbs,
Yes.
involving the sole and the nail bed. And in case of systemic examination, I would like to do examination of the chest, abdomen, and brain examination to rule out any focal neurological deficits.
Do you know if there are any ways you can know the phenotype of the tumor?
Yes, ma'am. By immunohistochemistry,
Very
I
good.
will know the phenotype of the tumor.
All right. Right. What treatment can be offered to this patient?
This is a metastatic malignant melanoma. So in this case, we need to do first chemotherapy. This which is it could be curative chemotherapy or palliative chemotherapy to reduce down the tumor size. And after that, we can do excision surgeries with safety margin. Then the safety margin will depend on the breast lobe thickness. But for the metastasis, we need to do chemotherapy and the radiotherapy as well.
If someone asks you to differentiate between skin carcinoma and melanoma, what are the
Yes,
features?
ma'am.
How would you differentiate the two?
Skin carcinoma, madam, you want basal cell carcinoma or squamous carcinoma?
You decide. How are you going to rule it out?
Okay, okay, ma'am. Melanoma is basically arise from the lower part of the lower layer of the epidermis, and it arises from the melanocytes. While the skin carcinoma or squamous cell carcinoma arise from the upper layer of the epidermis, and it is arise from the epithelioid cells. The next difference is uh, metastasis is more common in case of squamous carcinoma, but is less common in case of malignant melanoma. And the incidence is more in malignant melanoma, and while it is less in case of squamous cell carcinoma. And prognosis, in case of prognosis, melanoma prognosis is good, while the squamous cell prognosis is bad. And while
Well,
in case of
prognosis
liquid,
is not okay, prognosis, but it's more rapidly occurring. It's aggressive type as compared to
yes,
basal or
yes,
the,
ma'am.
yes, even the.
Or if we divide histological, the squamous cell carcinoma are basically keratosis, which may undergo ulceration and bleeding. While in case of the melanoma, these are the pigmented lesions with irregular margins and undergo different discolorations as well.
Okay, please tell me what are the genes involved in the formation or occurrence of malignant melanoma?
Yes, ma'am. The most common genes are uh, KRAS gene and BRAF
No,
gene,
not clear.
BRAF,
Yes,
BRAF, and the next one is NRAS, NF1, CKIT, and the less common genes are BRCA2 and CDKN2A.
CDK4 and CDKN2A. Yes. All right, and BRCA2. All right. What are the poor prognostic factors which contribute or which are present for malignant melanoma?
Yes, ma'am. Increased tumor thickness, increased depth of
Uh,
invasion, type of,
yes, okay, but before that, it's male, gender, old age,
okay, ma'am. Male gender and
ulceration,
old age, okay. Male
ulceration,
gender and old age is first, okay.
and then
Presence of
ulceration,
ulceration is second.
and then the site.
Presence,
If lesion
hmm,
is on the lower limb as compared to the
yes, ma'am.
upper limb, trunk, head, and neck, then it's the more prognostic. It's more poor prognosis. Okay,
Okay.
what are the skin conditions which are associated with melanoma?
Uh, yes, ma'am.
Xeroderma, if I give you
Desmo,
hint.
Xeroderma pigmentosa,
And
albinism, uh,
yes,
and, desmoplastic nevus syndrome,
very good,
and giant congenital pigmented nevus.
very good. What are other risk factors of malignant melanoma?
Madam, risk factors are immunocompromised patient,
Very good.
previous history of melanoma,
Yes,
red hair,
yes,
skin exposure, sunlight skin exposure, and the last one is
Hutchinson.
Hutchinson's melanotic freckles.
Very good. Right. When you have to excise a lesion consisting of
Yes, ma'am.
melanoma or malignant melanoma, what are the things that you would have to keep in your mind? Now tell me what you were telling before.
Okay, ma'am. So what have we need to keep in mind the basically the uh, in
Breast
tumor
slow
thickness,
thickness, yes, whatever you were
breast flow
telling.
thickness, and it will provide us about the margin that how much is the thickness and how much we need to remove the safety margins.
Yes, how
So, for
much you'll
example,
keep? Yes,
for example, if melanoma in situ, the excision margin is 0.5 millimeter. If melanoma is 1 centimeter, the margins are 1 millimeter. If it is 1 to 2 centimeter thickness, then the margins are 1 to 2 millimeter. If it is 2 centimeter, then the excision margins
right.
are 2 millimeter.
Okay, one is breast slow thickness. Other things, histologically, what would you consider? Ulceration.
Uh,
Then,
okay.
if you
Ulceration,
continue,
the type of melanoma, nodular or amelanotic melanoma, and presence of the lymphatics or perineural or vascular invasion,
yes.
and lymph
Mm,
node, presence of the lymph node
yes,
and distant metastasis.
involvement. Yes, all right, good, very good. Thank you. Maybe there is one more slide. Yes. Would you be able
Yes,
to
ma'am.
describe what you're looking at, the image?
Yes, ma'am. This is a round pigmented lesion which is present on
Is
the
it
skin
round?
and the size round or globular or oval.
Yes. How is it? If you can describe, is it raised? Is it flat? Is it
Yes, ma'am.
and it's not
It is a
round.
raised.
It's elongated kind of round and elongated kind of. Yes, more
It
dark
is
in
raised,
yes,
pigment,
yes,
black
pigmented.
in
Yes,
color,
yes,
uh, and irregular margins,
yes. And do
and
you
there is
see
no
this?
crusting. No,
Yes, but there
this is
is
I think
okay.
Crusting is there, but no ulcer is there. Crusting is there.
Yes, no bleeding or bleeding ulcer or yes, oozing ulcer, but crusting is there. It seems more or less
Yes, ma'am.
dried. What
So
more would you?
it seems like a melanoma on the present on the skin.
Yes, how are the margins? Are they well
Margins are
defined?
irregular.
Yes,
No, not defined.
Very good. Okay, thank you. Typical of melanoma.